So tazemetostat's an oral EZH2 inhibitor that's approved in the US based off of two different sort of distinctions. And so one is for patients who have an EZH2 mutation, who have had at least 2 prior lines of therapy. Now the prevalence of an EZH2 mutation is only about 10 to 20% of patients, so it's not a large portion of patients. But there's also another aspect where it could be considered, and that's for patients who have EZH2 wild type, who don't have an alternative standard of care that's attractive. And that's because we see the safety profile of tazemetostat is actually quite favorable. Very few grade 3 or higher adverse events. Very few patients have to stop therapy or dose reduce as a result of toxicity. But you could also be a little critical about the PFS. It's about 11 months for wild type patients. It's about 13.8 months for those with an EZH2 mutation. But we do understand why it may work in patients with wild type, and it probably has to do with augmenting the microenvironment or skewing the T cells towards a less pro-tumor microenvironment. And so that may lend itself well to combination strategies. And one such combination is lenalidomide in combination with rituximab. And so could we further augment that sort of microenvironment targeting by adding tazemetostat to that doublet? So a single-arm phase 1 study was done with a dose escalation, and then once the recommended phase 2 dose was determined, there was an expansion. And now what we're doing in this abstract here at ASH is we're taking that patient-level data, that phase 1b cohort of R² plus tazemetostat, and comparing it to a real-world cohort of patients who get standard of care lenalidomide and rituximab. And you can imagine we had to start with a very large number of patients that were treated in community practice and whittle that down to a very small population that was, again, matched based off the patient characteristics from that phase 1b study. And then when we look at the outcomes for those patients, again, it's not a head-to-head prospective randomized study, but at least it's a comparison of outcomes of interest such as efficacy and safety. It looks like the triplet compares quite favorably to R², and that really justifies the phase 3 that's underway, which is looking at tazemetostat in combination with lenalidomide rituximab versus R². So we're eager to see the results of that study.